Hello, welcome to this webinar offered through DAIReXNET, which is a national e-extension resource. My name is Kathy Lee. I am an extension educator with Michigan State University, and I'll be today's moderator. Our speaker today is Dr. Gary Oetzel from the University of Wisconsin-Madison. Dr. Oetzel grew up on a beef cow-calf farm in southwestern Ohio. He received his BS and DVM degrees from Ohio State University. He continued his education at the University of Illinois, where he completed his master's degree in veterinary clinical medicine. His research interests are in applied dairy nutrition and metabolic diseases such as milk fever, ketosis, displaced abomasums, and ruminal acidosis. Dr. Oetzel also is extensively involved in teaching veterinary medicine students. His clinical interests focus on troubleshooting and herd-based testing for metabolic disease problems in dairy herds.
Well, thank you very much, Kathy. And it is my pleasure to participate in this and to follow up on the excellent seminar last month from Dr. Jesse Goff, where he talked about hypocalcemia. What I'm going to do today is to focus more on the treatment side of hypocalcemia as well as preventing it in our herds. So just a little bit of background, just so we're clear on this. We know that hypocalcemia is a real challenge that cows face as they start lactation. I think we're very familiar with the energy draw of early lactation in milk production. I'd like to just draw your attention to the calcium draw that this cow experiences. I think it's equally amazing what cows do. Colostrum in particular and milk are very high in calcium, and the cows are going to have to draw on bone calcium to survive through lactation. They're going to be a negative calcium balance perhaps for about 3 months, and we'll draw somewhere on the order of 700 to maybe 1,000 grams of calcium from the bone over that time period, as Dr. Goff described to us last time. So what we've learned here over time, I'm getting a little jumpy on my cursor here, sorry about that, is that most cows, not surprisingly, experience a drop in calcium around calving as they make this remarkable adjustment. And we have learned that cows do not have to be recumbent or have classic clinical milk fever to be negatively affected by hypocalcemia. Shouldn't be a surprise. We know calcium is essential for muscle and nerve function, so skeletal muscle strength that we're very familiar with, as well as GI motility. So to keep the gut moving, to keep her up on feed, she also has to have sufficient calcium in the bloodstream. I think our key problems when we have this hypocalcemia, not necessarily with recumbent cows, but when cows are hypocalcemic after calving, is we lose dry matter intake after calving, which is a very bad time to be below what her intake should be. And so we see decreased milk yield as well as increased secondary diseases in these cows. So in today's cattle, and in our management in working as a veterinarian, we know it's about subclinical hypocalcemia. Our clinical rates are down, our diets are better, but we're still struggling on the subclinical form, which is low blood calcium around calving, but without any clinical signs. And I'm going to define low as less than about 8.6 milligrams per deciliter of total calcium. That is a higher number than our previous assumption that subclinical hypocalcemia started as cows went below about 8 milligrams per deciliter. The value for 8 milligrams per deciliter wasn't based on research where we knew that something bad happened to cows when we went below that level. It was just essentially a made-up number that we started with as researchers and said this kind of made sense, and so are some things published on it. But now we have data that allow us to see what really happens to cows, and the threshold has to be where something goes wrong with the cow. So we have 2 really nice published papers on this that put that threshold around 8.6, and I'm working on a 3rd one that I think is going to clarify this. So when you set that cut point high, around 8.6, which is where it is biologically, then your incidence of subclinical hypocalcemia is going to be high in dairy cows. You're going to be at least 50% of your 2+ lactation cows affected. That's even if you're using anionic salts. I'll show you some data on that in just a little bit. And because that cut point is high, the incidence is unavoidably very high. And as we've done some surveys, I'm familiar with a couple of projects on that. We run about 60% of 2+ lactation cows are coming in just across herds, coming in below the 8.6 cutoff. Nutritionists like this message because it tells them that, yes, you cannot manage hypocalcemia through diet alone. We get to a certain point, but it can't take us all the way. So we want to do the best we can with diet, but some hypocalcemia is going to remain, and you can't blame your nutritionist for that. I'll show you one of the studies that highlights this concept and some really interesting data from this. The study came out of Florida. They had 110 cows on a single commercial dairy, all parities of cows. Cows entered this study as pairs, normal calvings paired with the cow that had an abnormal calving, a dystocious stillbirth, and or twins qualified her for an abnormal calving. So they were looking dominantly in the study design at the effects of abnormal calving. The really neat thing that came out of the study was we learned a lot about hypocalcemia. So they were the second paper to show that this cut point for subclinical hypocalcemia, or something bad happens to cows, starts around 8.6 milligrams per deciliter. They bled cows frequently in early lactation, so if the cow went below 8.6 on any of the first 3 days after calving, she had a health problem, and that health problem was metritis, which is very prevalent in southern herds, particularly in the summertime. So a little background on these herds. You think, well, maybe there was some problem. No, they were feeding anionic salts. They were doing what they could on the prepartum period. Their pre-fresh DCAD was very low, minus 94 milliequivalents per kilo of dry matter. So a good stiff dose of salts. They still had 54% of their cows were hypocalcemic on one of those first 3 days after calving. And that was after I adjusted the data set to reflect the fact that they had selected half the study animals as cows with calving problems. Those cows do have more hypocalcemia. Otherwise, this study would have been over 60%. No cows had clinical milk fever, no supplemental calcium. I think this describes well-managed dairies with pretty good state-of-the-art nutritional management at this point. So what happened when cows went below the 8.6 threshold? They were at increased risk for metritis, and it was substantial, very biologically important, at 3.2 times greater risk, 2.4 times greater risk for postpartum fever. A lot of those fevers are from metritis. They have more ketosis. Their post-fresh BHBA, or beta-hydroxybutyric acid, our main measure of ketones, was higher, 1.0 versus 0.7 millimoles per liter. That was the average. The threshold is 1.2 for BHBA. So when a group mean gets up to 1, that's really quite high. And because these cows got off to a poor start, this carried into reproduction, and they had longer median days open, 124 versus 109, just for whether those cows were hypocalcemic or not coming in. They also pulled a lot of samples and did some very interesting work on immune suppression. We know that hypocalcemia is immune suppressive. They showed it very well in this study that the hypocalcemic cows had reduced neutrophil concentrations, as well as a reduced percentage of neutrophils doing what they're supposed to do, which is to undergo phagocytosis, which is engulfing bacteria, and then killing those bacteria with an oxidative burst. So those functions were lowered, so we would expect to see more metritis, which is what we saw in those cows. As metritis is dominantly a disease, it's a reflection of the immune suppression that a cow experiences right after calving. They were pulling blood samples during this study on cows frequently after calving, so we got one on the time of calving and then on out through day 4, and then later ones at day 7 and 12. Here's the cows who did not get metritis in this green line. They, we might say, read the book. They had levels that were reasonable. The group average around calving, and the group average dips down pretty low. We're going to know a lot of these cows will be below 8.6. They usually do hit the bottom or nadir in blood calcium concentrations the day after calving, not the day of. And then these cows continued to gradually get better. They really didn't get fully straightened out until we were out here a good week after calving. Then remarkably in this study, these are the blood calcium results for the cows who eventually got metritis. They could be diagnosed with metritis starting out here on day 4. So on the day of calving, they're the same, and then they drop significantly day 1. Cows that are going to get sick with metritis have a delayed nadir or low point in serum calcium, so it actually goes out to the second day. Then they gradually start to get better and stay below the cows who never got metritis. So this is hypocalcemia as a gateway disorder, illustrated very nicely with these data in herds where metritis was one of the major health problems. So hopefully we're all motivated out there to minimize hypocalcemia as we can in our cows. The nutritional means of prevention need to be done. That's our first line against hypocalcemia. Dietary calcium restriction is the traditional older method, and we found it's just very hard to get calcium low enough to actually upregulate these homeostatic mechanisms, so we don't rely on that one. The two things that we can do in herds with good feeding management are dietary acidification using anionic salts, or just in general paying attention to DCAD, as well as making sure that our dietary magnesium is high enough. And that usually means a little bit of supplemental magnesium from a good source into that pre-fresh diet. Now, Dr. Goff covered these very well last time, and herds should be doing what they can, working with nutritionists to do the best job possible through nutrition. But it's still going to leave us with about 50% of our cows below this biological threshold. So it gives us an opportunity to use individual cow treatments. We do have cows going through our maternity pens, fresh pens. You have opportunity to handle those cows. So we've got IV and oral calcium as options for additional supplementation that we can do. I'm going to focus here on just the individual cow side, and particularly the oral calcium supplements. I've done work with oral calcium supplements for about 25 years, and I've been a fan of these from when the first oral calcium chloride gels came from Europe over to the U.S. Oral calcium supplementation is clearly the best approach for any cow who's standing but showing some kind of signs of hypocalcemia. We don't give oral calcium to recumbent cows. You actually can, on occasion, get down cows up with oral calcium, but I'm concerned about safety of administering this, and if a cow's down, she needs to get up. And the fastest way to get her up is through the IV. So people might ask, well, where do you give IV, where do you give oral? But to me, that's pretty easy. If the cow's standing, it's oral. If she's down, it's IV. One of the things we learned is we got into this and got to working with oral calcium supplementation is that cows absorb oral calcium very rapidly. Peak levels with oral calcium chloride hit around 30 minutes after administration. That's very fast, and they sustain those levels for approximately 4 to 6 hours, maybe a little longer with some of our longer acting formulations. So it's not trivial the amount of calcium we can deliver. It doesn't completely mitigate all hypocalcemia, but it certainly helps. Now, I've been on this bandwagon for about 25 years, and will certainly acknowledge there's been pretty modest use of oral calcium by the dairy industry. Maybe that's coming from lack of veterinary involvement in designing on-farm treatment protocols, because something with hypocalcemia often gets into these protocols. And many times it's excessive use of IV calcium, and often that information did not come from a veterinarian. And we do know that protocols tend to be passed from herd to herd, not from veterinarian to the dairy producer. Another reason I think we've had some folks favoring IV calcium is kind of glamorous for herdsmen. We joke that it's glamorous for perhaps a year or two, and then it starts to get a little bit tedious to be handling the cows that much. But it's a little fun at first, and certainly some cows, given IV calcium that might be in early stages of hypocalcemia, show some short-term benefit. They perk up, their ears get a little warmer, and we think we've done some good. However, the physiology would suggest that we may be doing long-term harm when we give IV calcium and we don't need it. So I'm going to illustrate that with some of Dr. Goff's data. There's another new study that was recently published out of California that shows the same concepts. But this is a cow who was recumbent with clinical milk fever. She had a plasma total calcium of about 4. She was treated with a standard dose of intravenous calcium, and then they followed her blood calcium levels very frequently immediately after administration. So she jumps up very, very high. Normal range is in this 9 to 10 in here. She jumps up into the low 20s. At this point, we've put this cow near cardiac toxicity. And anyone who's given IV calcium to dairy cows know that it's very possible to kill them, and it is because of this fatal heart block. The other thing is it creates what we call a calcitonin response when cow's blood calcium gets this high. Calcitonin is not your friend when you're trying to get a cow off to a good start. It's the hormone that protects a cow against hypercalcemia. So it works against parathyroid hormone, or PTH, which is the one we want to have going in this cow to get her to mobilizing her own calcium. But we not only turned off her PTH response, we turned on this calcitonin response through the whole process of her calcium homeostasis into reverse. So it's really no surprise that these cows are hypocalcemic again below 8.6, 4 or 5 hours after being given IV calcium, and stay lower. And the new study out of California shows very clearly that cows given IV calcium even 48 hours after administration still have much lower calcium than cows that were just left alone or cows that were given an oral calcium bolus. So this does get cows up when we give IV, but it's not good for sustained support of calcium beyond that. We just want to limit it to that use. Otherwise, we want to be oral. If you are using IV, well, I hope you are, and if you're using that for the occasional clinical cases, we still do get, even in our best herds, whenever you have successful IV treatment of a down milk fever, it should be standard to give 2 doses of oral calcium after she gets up, the first dose after she's up alert, able to swallow, and the second dose about 12 hours later. That'll reduce your relapses approximately by half. And I think this also will help these cows get going faster, because they certainly struggle. Even after an uneventful clinical milk fever, cows are losing quite a bit of milk in the subsequent lactation, and it's very hard on these cows to get going again. So if these things are true and we are seeing modest adoption of this, we've had some changes. We have oral calcium boluses now, which are much safer, much easier to give, and have made oral calcium supplementation more practical. So I did a field study that was published a couple of years ago. This was with the BovaCalc product, an oral calcium bolus. It's calcium chloride based with some calcium sulfate. And our objectives in this study were evaluate the effects of oral calcium boluses. We just did 2+ lactation cows on milk yield, looking to sit the first test, and on health events before 30 days in milk. We wanted to focus on things that were close enough to calving and to this oral calcium supplementation. Did this in 2 large commercial dairies in Wisconsin. Average herd size between the 2 was 3,400 cows. We took all the 2+ cows we could get that calved the summer of 2010. That was 927 cows. These were herds that were already on low DCAD diets. They were nice negative DCADs. They were monitoring urinary pHs. They were in a very reasonable range and had very little clinical milk fever. In fact, between these 2 herds, as I went back and looked at the numbers later, we had 0.1% clinical milk fevers recorded in the prior year. It was actually probably a little higher than that. But this was clearly looking at oral calcium supplementation into a situation, herd situation, the least likely to respond to it, because we had just very little hypocalcemia to start with, or at least we thought. We did collect blood on these cows the day after calving, and about 53% were below 8.6. So even though it seemed like we were great, this is just the state of the art. Very similar numbers to the Florida study, around 50% on our 2+ lactation cows with anionic salts. will be below that threshold. So this was a randomized clinical trial. Cows were assigned either to be controls, no bovacalc boluses, or to get 2 boluses around calving. And the schedule that we have, I apologize for the slide here. It looks like the graphics came out a little interesting, at least on my screen. But here's the day relative to calving. Here's a graph that shows from a large data set out of Iowa State what the normal drop in blood calcium is around calving time. They come in, they drop the day before calving, they get their lowest point the day after, and they go back up. So we did our supplementation on the day of calving, right at the point of calving within 2 hours. And then the second bolus was just given the day after calving, which averaged about 20 hours. It was the next time they were locked up in the fresh pen, so that this was practical. We were covering the time period where cows are low. Sometimes people ask, gee, can I just give one bolus? And physiologically, that really doesn't make sense. We have to cover the cow for a longer time period. I think the better question is not, is it 1 or 2 boluses, but is it 2 or 3, or even 3 or 4? Remember when the calcium supplements first came out, they were all 4 treatment protocols. We've whittled it down to 2, and that's really bare minimum, and probably ought to be looking more at 3. But for practicality, we're going to show you 2. That's what we did. Looking to see how the cattle responded, also intentionally wanting to know if there were subgroups of cows that responded differently to oral calcium supplementation. Not expecting all the cows to respond in these herds, with very good programs to prevent hypocalcemia, could we find target groups where we could focus our treatment? So we were very interested in that. So as we looked at our 2 key outcomes for all cows that were supplemented, this would be what we call blanket supplementation. First test milk yield was the same, whether they got bovacalc or not. So NS means not significant, slightly more milk numerically. Health events were the same, not significant, slightly more health events for the supplemented cows, but nothing significant there to talk about. So it did no harm. One of the questions we had is if we have them on anionic salts and we give them a calcium chloride-based supplement, which is going to bring more chloride, is going to extend the period they're acidified, could that possibly be harmful? And we didn't think so, but this clearly shows that. Not harmful. Are there subgroups where it could work? And we found 2 subgroups where the supplementation had significant benefits. The first one was lame cows. We were doing locomotion scoring on cows during the pre-fresh period, and the supplemented cows with bovacalc had a lot fewer health events before 30 days in milk than those who didn't, and that was significant. We didn't necessarily expect this. This is new turf for us. We went into it to see what would happen, and this one does make sense biologically. Because a lame cow is already having trouble getting around, she's having trouble getting to the bunk, and this gives her a chance to maintain her strength, to not slip and fall, not get injured, and to maybe get up and eat a little bit more and reduce some of these diseases. So very nice response in the lame cows, if we could identify those. The other group that responded well was cows with higher previous lactation ME milk production. If those cows were supplemented with bovacalc, they gave more milk at the first test. So we looked to see, what is high? Where is there's kind of a cut point here where we saw more milk? And it was cows that were above average. In fact, 105% of herd average ME milk or better. So it's 45% of the herd, the top 45% of cows. Looking at a cow's ME milk production compared to herd average, that's relative value, or RELV, in your dairy comp records if you have those. And when these higher producing cows who were healthy, I think good cows, when they got more calcium, they did something really good with it. They made more milk. In fact, 101.4 versus 95.3, that's 6.5% more milk at first test. Very significant increase in early lactation milk for those cows. They had no other bottlenecks, so they were able to respond to this. So if we would target our 2 subgroups together, in my study I could combine those 2 groups because some cows were in both groups. They were both lame and high producing. So I had 444 4 cows out of the 927, or about half of the cows, 48%. Rerun the stats on these two groups. We got 99.4 versus 92.8 pounds of milk. Now we got the lame cows in there. Now it's 7.2% more milk at first test, so a significant increase. Lame cows are in there, so we can go back and look at health events. They were numerically lower, but just a little bit. That's not significant. So we're not going to claim that across the entire group of cows that we might supplement this way, just in the lame cows. But it is interesting that for a very large number of cows in the herd, we can improve milk yield in early lactation without impairing health. And that's very hard to do. If you just come in, leave everything else equal, and increase milk yield, classical example of that would be with somatotrophin, then there's going to be some accompanying health problems. In this case, we got the milk without impairing health. So everything being the same, it's really hard to hold health when you get more milk. There's a lot of data in this study. It was a lot of fun. We did also notice that the highest risk for hypocalcemia, we're already within 2+ lactation cows, so we've got to keep that in mind. That did not necessarily equate to the best response to supplementation. These are two different concepts. The most hypocalcemic cow may not be the one who responds the best. So, for example, there was no effect of parity when we did our study. We're already in 2+ lactation cows, and the older cows did not necessarily respond better. Now, they were more hypocalcemic, but they didn't respond better, probably because the older cows have other biological limitations. Calving difficulty, whether it be dystocia, twins, stillbirth, did not show up in our analysis. They weren't a special target group to give oral calcium. Now, we pretty much covered most of those cows if we were doing lame and high producing, but it would have added a few more cows to our treat list, but we can't say they benefited significantly. Again, I think those cows may have had other issues. So I'm going to finish with just a few slides that address the notion of which calcium source should a producer or a veterinarian be using. And there are a number of different products with different approaches out there. I can't be exhaustive about that, but I want to talk about some very nice research data, give you a few principles. We're looking mostly at 3 compounds that have been studied in the literature: calcium chloride, calcium propionate, and calcium carbonate. There are others out there in products or in some home mixes for calcium supplementation. These are the 3 that are quite common and that we know something about for sure. Calcium chloride is, if you will, our gold standard for oral calcium supplementation. This is some of Dr. Goff's work. 50 grams of elemental calcium as calcium chloride administered in 250 ml of water. This is a research protocol. We do not want you giving this in water. It's too dangerous, but it worked in the study. We tracked the blood calcium response. I'm going to show you several kinetic study results. To make everything equal across those studies, I just set the starting point to 100% of baseline, and we'll see how they respond over time. There's your peak at a half hour. That's a 30% increase. Out to 6 hours, they're about 10% over. That's a nice response. There's quite a bit of calcium under this kinetic curve here. Dr. Goff did 100 grams of calcium as calcium chloride, and we can pretty much agree that that's too much. Pushes them up to almost 60% over baseline, might kick in a calcitonin response, might be too much for some of these cows. So somewhere down in here seems like a more reasonable dose. This is a caustic compound. I told you don't mix it with water, don't give it that way. The risk of aspiration and getting pneumonia is just too great. The other compound that we see used pretty commonly is calcium propionate. It's more slowly absorbed. It's less acidogenic. In fact, it's just not acidogenic at all. Not as bioavailable, but it does work if you go up to higher doses. So Dr. Goff suggests 75 to 125 grams, about 100 grams or a pound of calcium propionate is the standard here. Now we're not at this point giving gels or tubes or boluses. This is a large amount. We have to mix that in about 5 gallons of water and pump it in. So we do create some safety issues with that. But the kinetics are good. If we compare this to our previous standard of calcium chloride, you'll see the calcium propionate at a higher dose, this was 75 grams of elemental calcium, is very similar kinetics. But you have to give more grams if you're going to use calcium propionate. It's not acidogenic. We're not going to get the kick that we get with calcium chloride. Calcium propionate is glucogenic, so it does yield glucose to the cows. Very good for cows who are also off feed, maybe a little later into lactation. We don't know if this is good for cows on the day of calving or day after, because these cows may well be hyperglycemic. And in fact, we can show you some blood glucose data here. Here's our chart, days after calving from 3 before to 10 after, so we're in about a 2-week span here. There's our calcium chart again that we showed you before. And here's the glucose over the same time period. We'll throw in normal glucose values. Cows are hyperglycemic the day before, the day of calving. They're kind of transitional the day after calving. And then they go into quite low glucose, as good milking cows do. We don't have empirical data on this, but I wonder if extra glucose is potentially harmful for cows right around calving. And that's certainly a possibility. The third common source of oral calcium supplementation is calcium carbonate or limestone. It's cheap, but it's simply not good. It's not soluble. It's not available. It probably invokes a little bit of an alkaline or alkalogenic response in the cow, which is going to impair absorption from the gut. It just can't get ionized in the gut. It's also going to impair mobilization of calcium from the bone. So when Dr. Goff did this and gave 50 grams of calcium as calcium carbonate and monitored these cows, there's your standard with calcium chloride, they didn't go up. And in fact, they went down a little bit. So not a good source for immediate correction. They will absorb that over time, maybe over 24 hours, but you won't see an immediate blood response. The Bovacal product that we used in our study, there is a very nice study that shows the kinetics of that. They had control cows that read the book. They went down, hit their nadir about 13 hours after calving, went back up. The cows with Bovacal, given the label protocol, run at calving, 12 hours later, had a nice increase, up about 12% over baseline, extended out, still up a little bit at 12 hours, and then gave the second bolus. So it does extend on. This is not enough to completely mitigate all of our hypocalcemia, but it certainly helps. So this slide here is going to talk about how I kind of divide up my calcium or just general nutritional supplementation. Cows around calving, they really need calcium. My preferred oral supplement, if you will, is calcium chloride without other stuff in it. Then once we get out into that, after the first day, then we go with calcium from various sources, then we go with glucose precursors, then we do potassium, then we do yeast and other things that may help these cows out. So to pull this together, where do I think we are right now in our maternity cows and how to use oral calcium? Well, I would say based on the data we have, if you ever heard with hypocalcemia problems, you got clinical signs, you're not using anti salts, you got jerseys, or you've measured hypocalcemia, you're 60, 70%, blanket supplementation would really make sense here. If your herds are like my study herds, then I do lame cows and high previous lactation milk production cows. That's going to require a little more management, but that's where you get the economic return. And don't forget these other uses of oral calcium. Early standing milk fevers, after IV treatment, and in early lactation cows that are off feed. We get secondary hypocalcemias. Let's cover those and give those cows a little bit of a boost. So that's what I have for you today. I would welcome any questions that you might have and appreciate the audience.
Thank you, Gary. And I think maybe you've covered this partly, but you talked early on that a lot of producers or not enough producers probably haven't worked with their veterinarian to develop treatment protocols. I wonder maybe you could talk a little bit about a good way to develop a successful treatment protocol.
Sure. Well, one of the things that we're trying to do is to very much encourage veterinary involvement into fresh pens with our producers, trying to show them the value of that. And one of the things that we do, I spend a lot of time in fresh pens, is just try to go and work the fresh pen with the producer. So this is for our medium and larger sized dairies where they're doing a lot of work on their own. Just see what they're doing. Just get in there as a veterinarian producer together, observe cows, observe protocols. Things come up when you do that. And, you know, the vast majority of our dairy veterinarians out there can recognize certain deficiencies, ways some things get done. And we just encourage this model of using that as a springboard and then getting veterinarians and producers working together for the best possible health on their cows.
So how about record keeping or monitoring, you know, health events through their records? Do you have any suggestions how to do that effectively?
Yes, it would be a somewhat long list, but health records are a challenge on dairies. You know, when you get done with a sick cow, a down cow, one of the last things you want to do is then go and record that well and be reminded once again of that disaster. Yet, as a consultant working with these, we need better health records in the vast majority of our dairies. So there are a number of guidelines for how that can be done. But the short answer is we need more information recorded on most dairies so that we can do the kinds of statistical evaluations that my group does, and I think lead towards some very meaningful results and improvements. But yeah, we need to get it done, and it's a whole other seminar on how that might be done most effectively. But please record as much as you can.
I would like to thank you very much for sharing your expertise today and very well thought out presentation. So thank you very much for that. I'd also like to thank the audience too for participating. So thank you very much, everyone.